This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thank you, Bernard. Thank you for promoting me. So I'm not the Dean, I'm the Deputy Dean. Yeah, very much less important. So thank you also to Darryl for inviting me to speak today, and get the task of the practical approach, I guess, to end-of-life care and the rapid response team calls. So what I'm proposing to do in the next 14 minutes is talk about we've heard a lot about it already, of the rapid response team and end-of-life, where resuscitation plans may or may not come into play, and the confusion, and then the various scenarios that you may face, or have faced, I suspect, and how you might deal with them. The only thing I'd say is that I am an advisor at the Australian Commission, so I may have a slight bias to the framework that is recently published. So one of the major challenges that we've heard quite repetitively today is that end-of-life care is probably a community issue, not least that not many people have talked about dying and what's important to them as they die. Only 8% in an intensive care population have actually got a sort of advanced care plan. Certainly when we audited 200 patients in Canberra, only 11% had an advanced care plan. So there is some work to do. So there's really uncertainties about what's important to people as they die. We do know that probably they want to die at home but end up dying in hospital. Indeed, many, many more people die there, and we're ill-equipped, if you like, with not enough resources going into palliative care. And so what happens is that you get this delayed initiation of comfort care and indeed thereby prolonged suffering. So there's a mismatch, if you like, probably what we would wish and what we get. And this delayed decision making is very evident when we did the 200 death audit by Brandon Burke, who's one of our senior registrars, and only in the last 2 days of life, in sort of a 2/3 was death actually, or dying was recognised. So very, as I say, supportive that we're recognising dying late. However, when you go to survey doctors and nurses in our own organisation, 96% of consultants say they're very confident about recognising dying. I suspect when the patient's actually taking their last breath, they're good at it. Interestingly enough, we then asked the junior doctors, are your consultants any good at recognising dying? They said, absolutely they are. So I'm thinking, whoa, maybe the consultant never pictures that, so they never actually see them. But when you ask the consultant about the nurses and the junior doctors, even though they think that they're okay recognising dying, actually the consultant thought that they weren't. About 40% thought that they were confident. So we have a big problem. We're not making decisions as a community. We don't seem to be recognising dying. And then what happens when you die? You have physiological deterioration, and hence you clash the two worlds, the lack of decision making and physiological deterioration. So in our own organisation, we've just seen the number of MET calls rise exponentially, although thankfully over the last 6 months they seem to have plateaued. But when you're seeing 2,000 MET calls a year, you obviously are going to bump into end-of-life care issues. And indeed, if we look at our own data in Canberra, the number of patients that are now experiencing a MET prior to death is increasing. So we're seeing an increasing number probably with end-of-life care issues. Interesting, this is those that are dying subsequent to a MET. In fact, it looks like those dying at the MET is decreasing. I'm sure not significantly, but certainly not rising. So I'm not sure what those data are telling us. What I have found fascinating, and I alluded it to last year, is that when we go back to look at our own data, the numbers of patients that we are seeing at a rapid response team call who have an NFR is going up. So when Ken talks about the fact that we're not recognising dying on the ward, I actually suspect we're recognising at least something. Why are patients being put NFR if we're not recognising something? What happens though, of course, if we then don't take the next steps and saying that, they're not for MET, they're not for intensive care. So with resuscitation plans, they can be useful, but I'm not sure what your own organisations feel, is ours are usually very unclear. And again, when we survey the nurses and doctors, to the nurses, how many times you have to clarify the orders, they're saying 40% of the time usually. And then we go to ask the junior doctors, how many times are you asked to clarify? 40% of the time. So nice corroboration, at least, of the data that the plan is unclear in many situations. And certainly, I guess, I'm sure that you might have seen, they're not for ICU, not for anything, not for a haircut, but they are for MET. And indeed, when we look at the major disciplines, I managed to harness 4 medical students looking at 4 major disciplines where lots of deaths occur. We then asked them to look at the resuscitation plan. So in 2 disciplines, 100% of those that died, this is looking at those that died in these major disciplines, there is at least a resuscitation plan. That's reassuring. But in this discipline, 33% of the time, when the patient died, there was no plan. I find that extraordinary. But then again, you also look for when they're not for ICU and not for MET. In fact, more often they seem to be for MET and for ICU, even though they're not for CPR. So I think we've got a bit of a confused picture happening. That's just to point out the various differences in disciplines. And so what happens, of course, we've got this array of patients that have no plans, and so who does make the plan? When we again look to the 200 deaths in Canberra, 40% of the time is either going to be the rapid response team doctor or the intensive care doctor. The rest of the time it was either the emergency department, and rarely was it the ward doctor or the home team doctor. But you could argue that only in hours is 30% when the team is here, and 70% is out of hours. So because we're operating an out-of-hours system most of the time in our hospitals, that means that the home team's hardly ever there. And so indeed, 30% of the time they are making the decisions, which I guess you could say is good, except the fact that most deaths are predictable. So why all this end-of-life stuff is relevant to intensive care? Well, it so happens that end-of-life care discussions are more common than actually administering CPR, so 20% versus 4%. So, and yet what do we train everyone to do? You must do BLS and you must do ALS, but let's forget about the conversations even though they occur more frequently. So of course we're looking to see whether the rapid response team actually need communication training, and really pointing towards the intensive care registrars because it's often out of hours. And if we can get the conversations happening, better still if it's in the community, in the emergency department, but right at this moment in time, the conversation is probably at the intensive care end, and you could start to think about what's important to the patient and maybe even limiting the amount of active treatment that we give patients. So how do we actually manage these calls? Well, it is not rocket science. So there's kind of 3 scenarios that you may face. The first scenario, and probably in some respects, the commonest scenario, where there are no treatment limitations in place, nothing related to end-of-life care, and therefore full treatment and with an intent to cure the patient. And of those patients, 25% will need intensive care admission. I suspect when we say 25% of patients who have a MET call go to intensive care, I suspect in there's still a percentage who are end-of-life issues. Then there's a second scenario where, as I alluded to before, there are now significant percentages of patients who have some sort of documentation that there is a treatment limitation. There are lots of markers of poor prognosis, and indeed, if anything, it's the rapid response team to provide support to help the ward team to come to the right decision, of course, with the patients and families involved. And I guess a lot of the time we're now spending writing that the patients would not benefit from further MET calls or indeed intensive care. But through that, there needs to be quite a lot of support and negotiation. Then the third scenario is when there's really ambiguous documentation of treatment limitations, and I actually think that's more frequent than it used to be, and that the treatment goals are very unclear. I mean, you get called to a patient where there is disseminated everything and they're still for everything, and you think, but hang on a minute, they're on palliative chemo. I'm not sure that as an intensive care doctor I can actually help them to provide a good quality of life. So everything's a little bit uncertain as to which direction we're headed. And of course, sometimes it cannot be easy to prognosticate. And sometimes it's because there is a disagreement between the patient, the family, and the treating team, and that there hasn't been a sort of conclusion as to where we should be headed. As I say, the disagreement between the team and the family can be because there's uncertainty about the prognosis of the patient, and also whether there's appropriateness of ongoing curative care in light of chronic comorbidities or functional impairment. So I think there are obviously some challenges that need to be faced when looking at those situations. And then probably what happens, or at least tends to happen, is that you end up, while you're having these discussions with the treating team and the family, you then have active resuscitation and often end up going to the intensive care unit. And so what happens then, of course, is that you really do need to facilitate very meaningful end-of-life discussions, probably not on the run by this stage, either in a ward environment where you stabilise things, or that you now had to admit into the intensive care unit. But I think it's critical, I mean, this is, again, not rocket science, is to really understand the patient and trying to get as much information from the treating team. I think it's important to have high-level conversations and not left to the juniors, so that consultants are involved in this conversation. And equally, when you're going to talk with the family, you must ensure that all the important members of the family are there, because sometimes you can be thinking that you're going one direction and suddenly a sister or a child arrives and you've no idea where they're headed, and in fact they may be thinking something completely different. So it is essential to make sure that you've got all the important people there. I personally think you need to be in a quiet, undisturbed environment. Too many times I've seen bedside chats where doctors standing up and having this loud conversation, I think in a very unhelpful way. So I think it's important to go to a quiet environment. And obviously establishing the story from the patient and the family, filling in the gaps, and repeating the story to provide the full picture. Because often what will happen to the chronic airways disease patients, they say, but they've just become sick. You think, no, I think this has been going on 20 years. You just have to look at the weight loss and the fact that they're breathless when they're eating. So I think it's slightly longer than just now, but I'm sure you've been familiar with those situations. It is critical to get to an understanding, and this is where I think Charlie Cork's work of my values, what sort of perceived quality of life is important to the patient, or does the family know what's important to the patient? And I think from all of that information you can work together to provide a sort of way forward, a goals of care, if you like, taking everything into account, and then communicating that with the rest of your intensive care team and of course the treating team if they're not there with you, which is often beneficial. And then, of course, it's imperative that you document and communicate those all very clearly, so that even when they do leave the intensive care unit, there's not then the repeat met for the same issue. And I think, as I say, you may sometimes be offering limited intensive care. So I think in conclusion, it's essential that we as a community raise a conversation about what we want, what's important to us when we're in our dying days. If we haven't got to that stage, then what's going to happen is in the acute care environment, we will be faced with these decisions until that's sorted out. And as we know, that rapid response team calls are often associated with end of life, and they're often out of hours, just because the out of hours percentage of the week is 70%. Only 30% is in hours, Monday to Friday, 8 till 6. And so our teams need to be trained up. I think they need to have adequate training to have proper conversations. I think the other thing, at least as an interim measure, to have clear resuscitation plans. Again, going back to our own data, when you're asking nurses and the doctors, there is often the need to clarify what's going on. Certainly in Canberra, we've just instituted, now this is the checklist. It isn't about establishing the goals or what's important to the patient. This is just really provide clarity to those that now are attending the rapid response team call-out. So in fact, one of the cultural differences is that we're not now, used to be like you had to take, is a patient for CPR, not for CPR. Now the decision triaging is, are they for MET or not for MET? And of course we get to audit these forms because maybe people are going to tick for MET the whole time because it's just that much easier, but who knows. Of course, I think as we go into the future, there is a nice framework for how we best do end-of-life care in acute care hospitals from the Commission. And on that note, I shall finish. But to thank the people that have helped me, Brandon Burke, who's our intensive care senior registrar, did the audit of 200 patients and allowed us to show the process of dying in our hospital. We're now going to hopefully repeat that in about 9 tertiary hospitals across Australia. We've done a survey of 500 healthcare professionals. Again, we're hoping to do that in the 9 hospitals across Australia. And the medical students were looking at the disciplines of, again, allowing us to look at the dying process. Thank you.